Hello. Today we're talking about diseases of the nervous system, and this is a short presentation as part of our ICD-10 Documentation Education for Clinicians. As with all of the sessions, this is a session that again is focusing on good documentation of diseases of the nervous system, and specifically we're going to need that now more than ever in this category. And we're going to be talking about certain specifics needed for many diagnoses, including pain. Now, codes from G89, pain not elsewhere classified, are used in conjunction with codes from other categories to provide more detail about pain. Remember, the improvement in pain interfering with activity is a quality measure seen in Home Health Compare. And so when recording documentation regarding pain, we need to know where is the pain, when has it started, how long is it lasting, and what is the patient doing to mitigate the pain. We need to know the specific symptoms, and you should be using a validated tool to record the pain. Now, depending on the patient's need, the pain scale might be an analog, 1 through 10. It might be a Wong Baker with the symbols of the facial expressions, smiley faces, etc. Whatever you are using, it's good to have it clearly delineated so that you can measure it on the next visit or with a certain frequency throughout the overall episode. Now, a code from G89 should not be assigned if the underlying diagnosis is known, except if the reason for the visits is for pain control and not management of the underlying condition. When pain management is the reason for the encounter, the pain is sequenced as the principal. And if the encounter is for any reason other than pain management, we're going to need to assign the code for the specific site of the pain, and I do mean specific, followed by the appropriate code from G89. Now, we can use pain codes as primary when the admission is for pain management, but we're going to have the documentation to code acute and chronic pain codes. When the pain began, the frequency, the duration, mitigating relief strategies. We also should have a chronic pain management score too. So as you're scoring your pain management, you should know too what would be acceptable for a patient who might have had chronic pain for the last 20 years. Are they shooting to get back to a 0 pain level? Or would they be satisfied with a 1 or a 2? You need to know answers to questions like that. Now, acute pain is defined as lasting fewer than 3 to 6 months. So this would include pain due to trauma, such as G89.11 pain due to post-thoracotomy, or G89.12 pain that is post-procedural, so G89.18. Now, chronic pain is pain that persists over that period of time and may be described as intolerable or disabling by the patient. It's good to know what they mean by intolerable or disabling. Not only should you be scoring it on a validated, standardized tool such as the analog tool or the Wong Baker, but you also should be noting what can they not do as a result of this pain. And we need to know, is it interfering with activities that they would like to do? We need to have specific identification of chronic pain if it's due to trauma, G89.21, or chronic postoperative pain, G89.28, or chronic pain syndrome, G89.4. Now, the detail to code acute or chronic pain, if the pain level is beyond what is expected, we need to know that. So if we're coding post-op pain and the patient says, I didn't expect the pain to be at this level, we should note exactly what did they expect. If we're coding the neoplasm code, we need to document the neoplasm site specifically. Now let's talk about the polyneuropathies and other disorders of the peripheral nervous system. Now for Guillain-Barre syndrome, we need to know if this is a recent diagnosis. When was the patient diagnosed? Is there acute polyneuropathy? And if there is, what do you mean by that? Is there tingling? Where? Is there numbness? Where? And not just on the foot. What part of the foot? ICD-10 is far more specific. So just saying there's weakness in the lower limbs, where? How long is it lasting? How long has it been lasting? Is there muscle pain? Where? Any difficulty in swallowing? With what foods? Are they getting adequate nutrition? Identify what an average day of food includes. You just can't say inadequate nutrition. You must be specific. Is there impact on bladder control? How? When are they incontinent? Is it only at night? Is it during the day? Is it a couple of times during the day? Is it 4 times, 5 times? What is it? Any pain in the neck or the head? Where? What spot? Do the spots change? Is there pain behind the eyes? Is there weakness in the eye muscles? Any sleep disturbances? And you already know what I'm going to say regarding sleep disturbances. When, where, how long? When are they routinely going to bed? Is there a routine? Have they breached the routine? When are they waking up at night? Are they eating something before they're going to bed? Has there been new stressors in their life? Is there tendon reflex involvement? Is there a history of hyporeflexia or areflexia? And for the polyneuropathies, we have to know the underlying condition. So is it N18.9 chronic uremia? Is it MO6.9 rheumatoid arthritis? Is it E16.2 hypoglycemia? And again, we cannot draw the conclusion that, excuse me, the rheumatoid arthritis caused the polyneuropathy. The physician has to draw that causal relationship. Let's talk a little bit about myoneural junction and muscle diseases. Does your patient have myasthenia gravis? If so, we must now specifically note what voluntary muscles are involved. Does the patient have ptosis? Do they have difficulty with opening and closing their eyelids? Is it bilateral? Remember laterality in ICD-10. Are they getting any kind of drainage from the eyes? Are their eyes, and frequently you're going to hear this, that the eyes seem to be sealing shut at night, and when they try to open their eyes, the eyes hurt and they get red because the drainage is sealing the eyelids. So the patient may very well need to keep moist cloths nearby so they can wipe their eyes before they attempt to open them before they're attempting to get out of bed or before they're attempting to awake. Do they have difficulty swallowing? Is it only with certain foods or with certain liquids? Do they need to use thickening agents with some liquids? Do they have chewing difficulties? Do they have speech problems? What about breathing? Do they have shortness of breath? Do they have dyspnea when doing certain activities? Are they on O2? How much O2? Remember, this is seen as a medication. How many liters? How frequently? Is it intermittent? Is it continuous? Is it only at night? Are their neck and limbs affected? Is there weakness in the hands? Which hand? Arms, fingers only? Arms only? Wrist only? Is physical therapy, occupational therapy, or speech and language pathology involved? Now, if your patient is diagnosed with muscular dystrophy, do they have muscle weakness? Is there evidence of atrophy? Where? How much? What is the extent? Do they have difficulty walking or inability to ambulate? Do they have joint contractures? Which ones? Bilaterally, singularly? Do they have muscle spasms? How long do they last? How frequent are they? You can see the depth of the specificity that's required. These records are going to get reviewed, and you're going to see that new position that we discussed, that certified nurse who happens to be assisting physicians in their documentation, beginning to be employed by more and more payer organizations to review records. And they're going to be looking for this level of specificity. So with the patient with muscular dystrophy, are there balance issues? How frequently? Is it a certain time of the day? Do they have a waddling gait? Is it later in the day when they get more tired and lack endurance? Is that when we're seeing this gait, or when we're having balance issues? Again, drooping eyelids. Are they getting the same types of secretions at night, sealing their eyelids shut? Do they have cardiomyopathy? What kind of diet are they on? Is the physician encouraging a seafood-heavy diet with fruits and green leafy vegetables? If he has, are they doing it? How frequently are they eating these types of foods? Is there pain? And again, you know what I'm going to say about pain. Where is it? How long does it last? How frequently? Is there something triggering it? What are they doing to mitigate the pain? And is there depressed mood? And again, for depressed mood, what is the level of a mood? Are we seeing that they're having difficulty with concentration? Are they feeling angry? Exactly what are we seeing there? Now, for the patient with Parkinson's disease, and we see this very routinely, we need to know when they were diagnosed, but more importantly, what are you seeing right now? Are there tremors? Is there evidence of pin rolling? If so, which hand? Any tremors when the hand is relaxed? Do they swing their arms when they walk? Most progressed Parkinson's patients have difficulty swinging their arms when they're walking. Is there a stooped posture? Or do they have slow movement? Any bradykinesia noted? What about their balance? And what tools are you using? And again, the frequency for which you can use validated tools helps you in justifying the reason, the necessity for visits. If you're showing that your patient, initially had a TUG score of 17, but with the advent of physical therapy and you're walking with them in education, it's now down to a 14. You're showing an objective statement of improvement. Are we seeing a shuffling gait? Is there decreased gesturing when walking? Are they able to provide more or less of their care? Any speech problems? Any lessening of facial expression? Remember, you're in there for a reason, and if Parkinson's is one of the reasons, then you need to identify why do they need skilled care. Has the patient's writing changed, gotten slower? These are things we have to identify. If the patient has Alzheimer's, and once again I stress, if they have Alzheimer's and they have delirium, we can't draw a causal relationship. If they have dementia, we cannot have a causal relationship. We cannot assume that. We must speak with the physician. There is an expansion of this code to reflect onset of the disease, and the coding instruction does state that we have to identify when an additional code is necessary if there is present of delirium, dementia with a behavioral disturbance, or dementia without a behavioral disturbance. So again, this all has to be documented because now the specificity of the coding is linked directly to that documentation. So we need to have the symptoms listed. Are there signs of any cognitive deficits? What signs? What cognitive deficits? What memory loss? Is it long-term or short-term? And just stating that isn't sufficient. Give examples. Is there difficulty with word finding? And here's a clear place where you could use some very fine short testing tools that would help you specifically give objective data regarding memory deficit or seeking of words. Are there visual spatial issues? Is there impaired reasoning? And again, any tool that you can use that demonstrates this in an objective fashion assists you with your documentation. And is there increased time necessary to complete tasks? So that would be mild. If there's moderate, and the doctor has noted moderate, you should be noting then what the significant language involvement is and what kind of difficulty with reasoning and judgment impairment is seen. And just saying there's difficulty recognizing family and friends, give a specific instance or instances. Also, understand if a person does have moderate Alzheimer's, learning new tasks or completing routine tasks can be more difficult. So you may need more time, and you're going to be educating. You can be presenting this to the patient, but obviously educating a caregiver as well. And if the person is diagnosed with moderate Alzheimer's, or if indeed it's noted now that the person has hallucinations and delusions, the physician needs to know of this because he may need to alter his diagnosis from mild to moderate. We do not see hallucinations with mild Alzheimer's. This is when, as it's progressing. You may also see increased paranoia, and the patient may have delusions involving TVs where they believe that someone's watching them on the TV. Now, with epilepsy, and we do see epilepsy at times with our patients, we need to know very specifically what types of seizures, the frequency of the seizures, that how many times are they having seizures a day, but also the length and duration of the specific seizures. We need to know if there are convulsions with the seizures. Are they generalized or partial? And if they are unilateral or bilateral, we need to know that. Is there a presenting aura prior to? And is the aura usually visual, hearing, auditory, or olfactory? And we need to know that. And if it's olfactory, then we need to know what seems to trigger it. So do they smell chocolate, or do bananas seem to trigger this, or highly seasoned foods, cooking? What is it, so we can specifically note that? Now, are the seizures tonic or clonic or both? And if they're both, we need to note, and if they are individual, we need to note if there's any contraction of the limbs, what type of extension and arching of the back is there, and is there a myoclonicity with any spasms, and any areas that are atonic. These are very important to know. Now, again, for any questions that you might have, please do not hesitate to give myself or Elizabeth Clark a call, or email is preferred because we frequently are traveling. So by all means, address any emails to susan.carmichael@selectdata or elizabeth.clark@selectdata.com. And we appreciate any comments that you have. Thank you so much.